Hello, everybody.
Hi, Gachuno.
Hello.
Hello.
Yes, we are glad to host you for this important symposium in the breakout session 2C. Good morning and good afternoon to all participants and the audience. I'll take this opportunity to welcome all and also allow my colleague, who is the co-moderator, to introduce himself before I say one or two things in terms of the ground rules.
Thank you, Professor Gachuno. Hi, everybody. My name is Abdon Mukalay, Professor in Public Health at the University of Lubumbashi, DRC. Welcome. Thank you.
Yeah, I think without further ado, we'll have the first speaker. And remember, if you have any question, you can post it in the Q&A. If there's any interaction regarding the volume or lack of clarity, you can use the chat box for that interaction. So without further ado, let's have Heavenlight Luzinge, who will introduce herself rather, and also introduce her subject. Every speaker has 10 minutes, and the technical team are very critical regarding that time. Heavenlight, the floor is yours.
Hi everyone, I'm Heavenlight Luzinge from Kilimanjaro Christian Medical University College. So should I present my screen or?
Yeah, kindly share the screen and you have 10 minutes.
Is everyone seeing the screen that I've shared?
Yes, it is quite clear.
Yes,
go ahead,
time
is ticking.
Okay, so I'll take you through the digital transformation in health education case of Kilimanjaro Christian Medical University College during COVID-19. We'll talk about objective, KCMUCo background, digital transformation, journey at KCMUCo, digital teaching and learning experience before and during COVID-19, COVID time and challenges and lesson learned. So digital transformation, Kilimanjaro Christian Medical University, established in 1997. It offers different health-related degrees such as Doctor of Medicine, Nursing, Physiotherapy, lab sciences, MEds, and MSc. It started with 15 students in 1997 and currently has 1,754 students. So the digital transformation journey at KCMUCo started in from 1997 to 2010. The main cause of transformation was shortage of faculty. So we had increased number of students yearly with the same number of faculty members. So that made a way forward for the digital transformation. We had a traditional or outdated method of teaching. We were using handouts to teach. We had poor infrastructures. There was no way of tracking if the students were really getting the materials that the teachers are providing. So that led to the way of digitalize the teaching and learning at KCMUCo. So teaching and learning started after the MEPI project, which is Medical Education Partnership Initiatives, identified the gap in delivery of the complex medical curriculum, and it was able to invest heavily in upgrading the information ICT infrastructures at KCMUCo. So the main purpose was to assuring successful deployment of the new technology. So we had to introduce the learning management system. We had to upgrade our infrastructures and introduce the learning management systems. So before COVID, we were utilizing different learning platforms such as Leo, Moodle, Lecturio. Also had different tools that we're using, Cohort, Screen. These were mainly for the engaging with the students. We had 1,239 students. Also, we had 41 courses that were active running in the systems. Also, we had 61 faculty members that were actively utilizing the system. So those are the system that we had, Lecturio, Moodle, and LMS. So because of COVID-19, all the universities in Tanzania were mandated to close on 18th of March. With the highly invested ICT that built for over the years and the pre-existing e-learning practices rescued the situation in maintaining teaching and learning without much interruption. So various interventions were undertaken to promote a transition to complete online learning. So we had to re-engage and introduce new users in the system. Following the order from management, we had to continue with teaching and learning. So we had to introduce some of the users that are not utilizing the system. So we had to import them in the system and show them how they can go about with the system. Also, we had to share the information. So from the time of the close of the university, all the important information such as manual, timetables, links, were all shared through various means with the system available, emails, and social medias. Also, we had to conduct different orientation to the users to show them if they've forgotten anything. We had to orient them. Also, we had to orient the new users that were first introduced in the system. We had to introduce other e-resources, e-resources such as Zoom, Google Meeting, which were mainly for the video conferencing. This replaced the face-to-face that we were not having during the closure of the university. So we had also to intensify the use of support systems. So we intensified the use of support systems so that any students, if students or faculty members are having any challenges, they can post in the system so that we can help them at any time. So we were using even WhatsApp to help the students and faculty members whenever they get stuck. Also, we had to do follow-ups if the teachers were really uploading the materials and the students are really downloading the materials, or if the teachers were really teaching the students, and if the students were able to attend the lectures that were done by the faculty members. So I welcome my colleague Glory to go about the survey that we took during the COVID-19 time. Thank you.
Good morning, good afternoon, good evening. My name is Gloria Ibrahim, and I'm Heavenlight's colleague, and I'll be taking you through the survey, the study that we took. It's a cross-sectional study that we took to eligible students and faculty members to see mainly how do they perceive the teaching and learning during that time. So the study actually took took place in 2010, and we had quite a number of students and quite a number of faculty members. And out of that study, we actually were able to get some attitude from the students, like how do they take the e-learning platforms. So we actually found out that the uptake of the e-learning platform increased by 15.4% to students, but for the reach to faculty and 22.5% in our systems. So as you can be able to see already in the system, as faculty also we're able also to get faculty teaching and learning objectives, and the consensus were 81 use of the video conferencing increased. So despite all that, we faced some challenges. The number of users kept on increasing, but we had less number of faculty. But at the same time, we had great number of students faced with affordable mobile internet bundle, and there was a fear of change. So despite all that, and we were able to pre-plan the use of system and all that, we found that in Africa, it's actually very necessary to.
Time is up. We need to have the next.
Okay. Thank you very much, and you're very much welcome to Tanzania.
Okay, Abdon will introduce the next speaker.
I need to be able to share my screen.
Please, you can share your screen.
Okay, thank you. Mr. Fred Collins Semitala.
Okay, great, thanks.
Please, 10 minutes.
Thank you very much. Are you able to see my presentation?
Yes, thank you.
Okay. So, good afternoon, everyone. Dr. Fred Semitala. I work with the Department of Medicine at Makerere University, and I also work with Makerere University Joint of in-service online interprofessional education to health care providers at health facilities to improve HIV performance indicators. So the background to the outline to the presentation, online case-based modules that we are offering, and the lessons learned. Education provides an opportunity to retool HIV healthcare program, which is Education for Interprofessional HIV Service Delivery in Uganda, is a Stripe HIV partner, which is based at Makerere University. This program adopted the online interprofessional education modalities to lessen COVID-19 related restrictions and barriers to learning. But before that, we were using face-to-face training. And since inception in 2019, we've trained over 1,000 learners. And so the case-based HIV training sessions sessions are facilitated by an interprofessional group of faculty. For this, but previously the training sessions, as I mentioned, we were getting many trainees were not as a gap in terms of how quickly they could impact on the HIV indicators, and also how we could easily track the performance on those indicators that I will highlight. So the study aims for this interprofessional education approach that integrates assessment of HIV performance indicators and targets healthcare providers who work together at the same clinic. And we also wanted to determine the post-training performance on the selected HIV indicators at the selected health facilities. The indicators which were aligned to our training modules included viral load coverage, viral load suppression, annual retention for key populations, viral load suppression for key populations, and also the number of eligible clients receiving pre-exposure prophylaxis, as well as the annual retention on the pre-exposure prophylaxis. So to run this program, we introduced our training approach to the leadership at one of the PEPFAR implementing partners, that's the Infectious Disease Institute. Through the leadership, we are introduced to the monitoring and evaluation department at that implementing partner. And we worked with the M&E colleagues in that department to identify HIV clinics that were suboptimally performing on the indicators that I've shared in the slide before. So we aligned those indicators to our modules, and our modules, the modules we are offering at this stage are 4, and each module is offered for a week. We have a module on ART adherence and evaluation of virologic failure. We have another module on health system building blocks, delivering high quality care to people living with HIV. We also have a module on pre-exposure prophylaxis and care for key and priority populations. And then we have a module on end-of-life care for patients. And for each of those modules, we aligned the performance indicators in blue, as you can see. So the methods, as I mentioned, we had been introduced to the M&E, and then we're also introduced to the IP manager for the different HIV clinics. And having identified the facilities that were not performing optimally on those indicators, we were able to select any facility that was we selected some facilities that were performing poorly on any of the 2 indicators listed. And we offered the 4-module training program with mentorship from the line managers. So the line managers from the implementing partners worked with us, and they participated in the training, and they would continue to provide ongoing mentorship. This slide, I've not labeled the names of the clinics for confidentiality, but you see that most of the facilities, you see the target in the second column and how the performance of the sites was. For example, in the second row, you see that one of the facilities had only a 10% retention of individuals who had been put on pre-exposure prophylaxis after 12 months of follow-up, and yet the target is 90%. So in summary, we selected the HIV providers, enrolled them on the program. We created student accounts on the LMS and shared login credentials. We updated user profiles and how to complete a pre and post test for the learners, and also uploading their assignments. To enhance continued communication, we created WhatsApp groups, and also we instituted, we worked with them to institute continuous quality improvement projects that will be assessed by the representative from the implementing partner. So progress so far, we haven't, this training ends this week, but we enrolled, we targeted to enroll 59 participants, and out of those we are able to get 55 who have continued with the training. More than half are female, and these are health center 2, 3, and 4 in that proportion. And in terms of the health professional cadres, we have a variety: nurses, counselors, clinical officers, medical officers, data people, laboratory, and others. So in terms of progress, sorry, that's what I've presented. So the lessons we've learned from this is targeted training interventions for interprofessional practice have a potential to improve HIV treatment outcomes. However, this is a multi-layered approach that requires engaging multiple stakeholders. In fact, earlier on, we had thought that would go through the Ministry of Health, but it got so complicated. We are still pursuing it for a larger coverage, but we wanted to start with an implementing partner who covers at least 2 districts to use the lessons learned before we go back to the ministry. The other issue we learned is, the other lesson we learned is that we need to adjust. So there is a big need for adjustment amongst competing priorities in the setting of the COVID-19 upsurge. So many of the health providers would love to attend these trainings, but they have so many commitments which make it complicated for them to participate in this kind of training. And so this, to get this moving, will require additional innovations, particularly to demonstrate relevance of this program among the many priorities that healthcare workers have in the setting of COVID-19. I would like to acknowledge the participating institutions, the collaborating institutions, and thank you so much for listening to me.
Thank you so much. Please, Professor Gachuno, next presenter.
Yeah, good afternoon once again and good morning once again. So we'll have our next presenter, who is none other than Catherine Mubita Ngoma. Catherine, the floor is yours.
I am unable to share the screen. I don't know.
Technical people, could you kindly assist Catherine Mubita Ngoma?
Catherine, please, you can share your screen. It's enabled. Fred, please, can you stop share? It's gone. What is this thing?
Catherine, the clock
Hello.
is ticking, please. Yeah, we can see it now. Go ahead.
Okay. Thank you so much. My name is Catherine Ngoma. I am a senior lecturer and PI for HIV UNZA School of Nursing project. Okay, the presentation outline is as indicated. I think I'm having a challenge.
Just press the.
Hello?
Go ahead, please.
Yes, please. The background information. Okay, the Stripe project. Those are the members of the Stripe project. I'm having a challenge with the.
Hello?
What challenge? Because the clock is ticking and just you have the cursor or.
Hello, Catherine. Please, I'm
Yes.
controlling your
Hello?
slides for you. You can go on with your presentation.
All right, okay, thank you.
You're welcome.
So the University of Zambia has two campuses, the Great East Road campus and the Ridgeway campus. So the University of Zambia School of Nursing Sciences is situated at Ridgeway campus, and it's one of the Stripe awardees. And the Ridgeway campus has 4 schools: School of Nursing Sciences, School of Medicine, School of Health Sciences, and School of Public Health. Next slide. Next slide. Hello? Next slide, please.
Alima, please, could
I don't know.
Sorry, we are having some challenge
Okay.
here. Please go on, yes.
Okay. So in year 1 of the project, the UNZA School of Nursing implemented level 1 Stripe HIV engagement and adapted Stripe training. This was the face-to-face training. So the final year disciplines and newly qualified health professionals. Next slide, please. Hello? Okay, so the Stripe Zambia project conducted also a facilitators training. And the participants were medical doctors, nurses, biomedical scientists, pediatrician, public health specialists, and pharmacists. Can I have the next slide? Okay, so those were the trained facilitators. Next slide. Okay, so training with pre-service students, we had 2 interactive case-based training with pre-service finalist students from different health professionals. And also we conducted one training using the COVID module, basically to equip the students with knowledge on COVID-19. Next slide. Next slide, please. Okay, so to integrate innovative approaches that will systematically leverage and strengthen HIV training and professional networks and target improving outcome for people living with HIV. So that was the purpose. Next slide. Okay, so as I said earlier, we conducted case-based training with students from the University of Zambia and also Lusaka Medical Apex. The total number of the students trained was 61. This was the pre. Okay, so the second workshop with pharmacy, biomedical, and nursing students. Next slide. Okay, so what technique during the case-based training? So the jigsaw technique involves putting parts of the assignment together to form part of the task in a similar way, like fitting part smaller group of 5 and 6 each. Each group having an appointed leader. So with each group, we had to master the slide. Oh my God. So within the small group, students discuss the tasks, reconcile the point of view, and synthesize information. Then each group made a presentation to the large patient, the assistance and interpersonal education. Next slide. Okay, so the analysis was based on 4 compulsory modules, that is module 1, 3, 4, and 17. So from this table, we can see that from pre to post test, the students scores. So module 1, we can see it was 81.8, but after the post test, the knowledge increased, the knowledge levels. Next slide. Next slide for confidence as well as interpersonal education. So we see that the training for confidence as well as interpersonal education. Last slide.
Time is up, please. We need to have
Next.
speaker.
Last slide. So all in all, the findings showed an improvement in students' knowledge levels from 60 on pre-test to 81. So it could be concluded that the jigsaw group technique enhances group participation as indicated by the facilitators and also the students in the post-test. Then the interpersonal education appears to enhance learning and also other positive attributes among healthcare professionals. So therefore, having a strong HIV team is likely to achieve patient engagement with the healthcare system. Thank you so much. Thank you.
Thank you so much. The next presenter is Mr. Ian Couper. Please, the floor is yours. Could you introduce yourself, please?
Good afternoon, everyone, and it's good to be able to speak to you. I'm speaking to you from Cape Town in South Africa on behalf of the Sunstripe team at Stellenbosch University. Sunstripe, you can see what it stands for, was established in 2019 as part of the Stripe project already. And as part of that, like the other Stripe projects, we delivered 2-day face-to-face HIV workshops, and we're doing that in the rural areas of 3 of our provinces in South Africa. And the way we ran these was that it was very much engagement of interprofessional teams. There was scenario-based learning focused on patients, active learning through interaction, and facilitation by a range of different healthcare professionals. Along came COVID-19, and South Africa in March last year went into an early hard lockdown, and we could not continue in this way. So we started developing guidelines for interactive interprofessional workshops using Zoom, and took the COVID-19 module that had just been released a few weeks before that by Stripe into an online workshop, which we delivered as 2 90-minute sessions on 2 afternoons during a week. And in that, we retained some of the same features that had been there in the face-to-face workshops, particularly the learning in interprofessional teams with facilitators from different backgrounds, using the scenario-based learning in that process, and making sure there was interaction. So we were still getting the active learning component in our online workshops. Subsequently, we took what I experienced from the COVID-19 module, and we adapted and delivered the HIV modules online as well. And that's been an ongoing process, also as interactive interprofessional workshop-based processes. In addition to that, rising from this experience, and because we wanted to mentor teams, we developed an online teamwork and collaboration module to support their ongoing development, and also worked with Stripe to develop a well-being and compassion module, very much responding to the issue of increasing stress and burnout in the context of COVID. So the aims of the workshops online were to ensure that everyone has access to these opportunities, to offer information for everyone, and to also overcome barriers both of professional identity and of geographic location. In reviewing this, we reviewed and quantified the workshops we conducted, we reviewed the feedback, we reviewed our own reflections, and offer some lessons from that. So in terms of the COVID-19 module, we trained over 500, over 500 people in our faculty, and both students and staff in terms of the COVID-19 module. And as you can see, very much right across the professions, although a particularly large group in medicine. This year, as we've continued with the HIV modules and the other 2 modules that I mentioned that we introduced, we've been doing that more widely across the country, Eastern Cape, and other. The difference to some people have attended more than 1 workshop, particularly when you get the HIV modules, they might have attended 3 or 4 modules, but then it counts as separate participants, but actually it's the same individual. That happened less so with the other 2, but we even had some people coming back to that, although some of those people are facilitators. Again, a breakdown across a range of professions, as you can see there. And in this case, nursing was much more previous year's process. So what did we spot was the fact that we still had these breakaway discussions and interactions. And the standing of the role and values. We've started doing some work following up 4 to 12 weeks afterwards to hear what people have retained. And you can see the influence of these features on what people retain in terms of their knowledge. And they refer back to specific stories or anecdotes or things that came up in linking their knowledge to that. People really enjoyed working together with their colleagues in the team. Sometimes people they didn't know particularly well. Others times it was a team that they very much worked with. They appreciated the atmosphere. They felt that they could learn from their peers, that there was openness, that there wasn't judgment, that you could make mistakes, you could offer ideas, and that was very much what we tried to create in the workshops. There was also an important development of technical knowledge and skills. It wasn't just a nice time to talk and have interaction, but they felt that they were gaining important knowledge and skills. And for most of the modules, we have some kind of pre-reading or guidelines before the module, and people felt that that was also useful in helping them to prepare. Some of the challenges they raised, the structure of the workshop, that it was, the challenges of being online essentially, and having to move in and out of rooms and things like that, that people found challenging. There were some challenges that were content related, especially because of the multi-professional groups, that some professions felt some of the content was less relevant to them than others. So that was an issue in terms of relevance for everyone in terms of what we're presenting. Time allocation, sometimes they felt some of the discussions were too short or too long. Managing time is a challenge with going in and out of breakaway groups. And the timing where we use 2 afternoons in a week, we found actually now where we have another workshop that takes 3 hours, it's better to do it 3 hours on one day rather than 2 separate days of 90 minutes. The facilitation method, where we were making sure that learning came from the participants, not from the facilitators who weren't teachers. Some people found that challenging. Not everybody was able to access the resources and materials beforehand. And then technical considerations in terms of connectivity and losing connection, and etc. What are the key learnings that were cited across the board? And this is generic because it's across a number of different modules, but some of the key things that came out were people enjoyed the notion of courageous leadership, of people embracing vulnerability, very much from the wellness module, that none of us has all things sorted out. But even in all the modules, the fact that the facilitators presented themselves as learners as well, which is the last bullet there as well, as part of that vulnerability. Understanding that everyone sees things from their perspective, which is critical in a team and working with different professions, and we need to hear that. Using the body as a metaphor, which used in the teamwork module, was something that people really enjoyed and have remembered. Self-compassion is important in care, and if we don't have compassion to ourselves, how do we have compassion to others? And the need for trust as we work together as teams. Facilitator feedback. They found it challenging sometimes to be facilitators rather than teachers, but they learned from that and all the time learning in their facilitation, and often carried that over to other activities. They found it enjoyable, and facilitators want to come back and be facilitators again. They do find it challenging sometimes to decide what information to give and how much you actually wait for information to come from participants. And people, surprisingly perhaps, but they really enjoyed role plays and reflecting on the role plays, and that's something we've introduced quite a lot in the different modules. As a project team, we felt that coming as a project team across professions, we can generate ideas through our collaboration across professions that has helped us to think differently about developing and delivering these sessions. And so it's been a powerful learning process for us as a team. We've learned that sometimes very simple activities can actually be very profound. It's about how one uses them and reflects on them. We also note that participants are looking for practical tools rather than theory, which they can actually go and find, online or on books. One of our ongoing challenges is a practical thing, is that people often register for workshops, but then don't actually join on the day, which is very frustrating in terms of planning and having enough facilitators. In summary, in terms of our reflections, we feel that process is as important as content. In other words, how we conduct the workshops is just as important as the content we use in them. We've seen that the small group process of interactive and interprofessional groups is really powerful and teaches far more than ever we could teach. We do need to do this on an electronic platform that enables this, and that we've used Zoom and we found that it works for us, but there are challenges at times. Webinars don't work for us. We need a workshop and interaction. These can be energizing or exhausting, and depends how they're conducted. And it's amazing sometimes how energized we found the facilitators were at the end of a workshop when we expected they might be exhausted. And that's very much about how you conduct it. And our ongoing question for us that we ask ourselves and anyone else, but there's so much information out there, so much online. How do we demonstrate the unique value of what we are offering? Those who have participated have really enjoyed it, but those who haven't, they see the title, they see the subject, and they say, why should we participate in that? And that's an ongoing question for us. Thank you for your attention. It's been great to be part of that, and I'm happy to take questions.
Thank you so much for time management and the content. Thank you. Professor Gachuno, the floor is yours.
Now we'll have the last presentation, and I would urge the participants to write any question or comments that they would want. Catherine, can you switch off your video, please? Yeah, so I would urge anybody who has a question or a comment to use the Q&A, and the panelists are requested to respond appropriately to the questions that may appear there. Now we'll have the last speaker for this session, Berhanu Elfu Feleke. Kindly share your slides, and you have 10 minutes. Is Berhanu in the house?
Hello, Prof. Please, Berhanu didn't show up. He is not, he couldn't join.
Okay, and I'm meant to understand. So we have, we actually late 10 minutes because we should be having the break now. So I would urge anybody who has questions, kindly post it. But essentially right now, we're already 5 minutes late. And I think we should just break before we go back to the plenary, unless I stand guided by the technical team. Alima?
Hello, please.
I think
still
that
have
is the
10
correct.
minutes, so we can take questions.
I think these 10 minutes are meant for people to have the break, because the plenary should be starting in the next 10 minutes. Maybe we can have 5 minutes, and then we'll have 5 minutes break.
Okay,
now,
that's fine.
I can see in the Q&A, Jog has said, great presentation and projects. This is for Professor Couper. Do you expect to go back to face-to-face training after COVID, or do you believe online training is good enough? Couper, the floor is yours. Ian?
Yeah, sorry, I was just trying to unmute myself. Thank you. Yeah, that's a good question, Bjork, because, you know, we've been enjoying this way of doing it, so it's easy to get comfortable. But we've actually agreed very much that nothing beats face-to-face. And so when we get to the point where we can go back face-to-face, we will certainly aim to do that. Particularly things like our wellness and compassion module and our teamwork and collaboration module. It makes a complete difference to be face-to-face. So yeah, we will hope for that.
And I can't see any other question. In the absence of any other question, I think we can now take the break. But I would request Abdon to stay tuned so that I can discuss with him one or two things. I think the rest of the participants, you can now have your nutrition break with coffee or whatever at your own expense before you tune back to the plenary. Thanks, everybody. And thanks so much for the plenary. For the panelists, well done.
It's a pleasure. Thank you for the opportunity.
Everybody else can log out apart from Abdon. The rest of the participants, you can log out. Abdon?
Yes.
All right, so you have my email. I think I'll send you what I've done for my summary. Then you can insert and then share with the secretariat.
Okay, thank you so much.
Thanks, Abdon. I think we can log out now so that we can go back to the plenary. Thank you.
Yeah, thank you so much. Thank you, technical team.
Thank you for.
On nous jamais. Namanale.